waiting for, we'll talk about glomerulonephropathies. So a glomerulonephropathy is essentially a glomerular nephronopathy, so there's a pathological process going on with the glomeruli and the nephrons. Glomerulonephropathies, there's so many different types. They can be primary, they can be secondary, they can be relatively benign, or they can be very sinister. They can be rapidly progressive, or they can be very slowly progressive, or not at all progressive, and they just spontaneously get better, or they get better with treatment. They are a heterogeneous group of disorders, and they cause many different things. For example, they can cause a nephrotic syndrome, which is essentially loss of protein in the urine, or they can cause a nephritic syndrome, which is inflammation of the glomeruli and the nephrons, and that will cause blood in the urine as well. So a glomerulonephritis will inadvertently cause a nephritic syndrome. So a nephrotic syndrome is essentially a syndrome which causes protein loss into the urine. These patients are defined as having more than 3.5 grams of protein in their urine every day. Now, you can have proteinuria, i.e. protein loss in the urine due to a problem with the kidneys, which isn't bad enough to cause 3.5 grams of protein in your urine a day. So there is a spectrum of disease with glomerulonephropathies, where some can cause just a mild proteinuria, some can cause more proteinuria but not enough to cause symptoms, and then it can cause enough for you to have this specific amount, 3.5 grams of protein in your urine every day, which is generally the amount which is required for you to have quite bad symptoms. So nephrotic syndrome, it can also be defined with a protein-creatinine ratio, which is just an easier way of defining it because you don't always want to collect 24 hours worth of urine to find out if they have 3.5 grams there. Clinically, they look like they have nephrotic syndrome. You just want to get urine sample, and this is a lot easier to handle than this, for example. So a nephrotic syndrome, because you have protein loss in the urine, you also have low albumin, okay? Albumin is the main protein that we lose in our urine with nephrotic syndrome. That's because it's a very common protein found in the blood, and it's responsible for keeping water within the intravascular space, i.e. within the blood vessels, and not leaking out everywhere, into your legs, into your lungs, into your heart, all of that stuff. And that's just simple osmosis, as you know. So albumin helps prevent osmosis from occurring and therefore having all of the water in your bloodstream leaking out everywhere. So if you have a nephrotic syndrome, you have less albumin, you have edema, you have fluid all over the place, and you can even get fluid on your lungs that can make you breathless and make you hypoxic. So, nephrotic syndrome, you have proteinuria, and you have an edema, and you have a low albumin level as well. You also tend to have high levels of lipids, and this is to do with, the protein loss. You also have high blood pressure as well. You can even be more predisposed to getting infections as you lose some of the immunoglobulins or immune complexes associated with fighting infections. And you're even at a higher risk of getting blood clots, higher risk of thrombosis, PE, DVT. And this is because you lose antithrombin free, which basically follows the albumin that you lose in your urine. So, to summarize, nephrotic syndrome, it is a spectrum of protein loss, but it must be a minimum of 3.5 grams of protein, but it can be anything more than that. But nephrotic syndrome, you can have less than 3.5 grams of protein and not be nephrotic syndrome, but it will cause a similar problem. And nephrotic syndrome is defined as protein in the urine, low albumin, edema, high lipids, and you may have hypertension, infections, thrombosis, things like that. Just remember, for it to be a nephrotic range proteinuria, you have to meet the criteria of 3.5 grams of protein in your urine every day, or a urinary creatinine, a protein creatinine ratio greater than 300, I believe. So that's nephrotic syndrome. What's nephritic syndrome? Well, glomerulonephritis will cause a nephritis, a nephritic syndrome. There will be blood in the urine. Again, like nephrotic syndrome, this will be on a spectrum. It can be microscopic, so you never know there's blood there until someone dips your urine and finds it. Or it could be macroscopic, so just enough for you to see. It could just look like a rosé, a rosy coloured urine, or it could be really bad and it just looks like pure blood, which is what we call frank hematuria. Now remember, there are other causes of frank hematuria, commoner causes as well. This could be due to infection, prostatitis, kidney stones, bleeding from trauma due to, a catheter that's been put in, or bleeding from a tumour. You should be thinking of all of these causes as they're very common. But if you don't think it's any of these and they have, a problem with their kidneys or they're unwell, they may well have a glomerulonephritis going on. Nephritic syndromes tend to be more aggressive than nephrotic syndromes. Now, nephrotic syndromes is proteinuria, but some nephrotic syndromes you can have a bit of blood in urine, and some nephritic syndromes you can have a bit of protein in urine as well. And often with nephritic syndromes, the amount of protein in urine can actually correspond to how bad a disease is as well. So nephrotic and nephritic syndromes, they sit on a spectrum of proteinuria or hematuria, but they also both sit on a spectrum of benign to very sinister, from slowly progressive to rapidly progressive to treatable to untreatable. And each glomerulonephropathy will have its own, disease course and its own prognosis. There are some types of glomerulonephropathies which have their own subtypes, and some subtypes will be benign and some will be more severe. So minimal change disease, for example, is commonly touted as a very benign condition, but actually, a third of patients, they have relapsing disease and it's not responsive to treatment. So even specific glomerulonephropathies have varying sort of disease courses and prognoses. And that's what makes this topic so difficult. There's so much going on, there's so much to learn. As a general rule, if you want to treat a nephrotic syndrome to try and reduce some of the complications and potentially reverse some of the proteinuria, you treat them with what I will call conservative management. And essentially that's, a combination of salt and fluid restriction, treating their high blood pressure with angiotensin receptor blockers or angiotensin converting enzyme receptor blockers. So these ACE inhibitors and their ARBs, they're really important in managing patients with kidney disease, really important. So those are really important things to do. You also need to manage their lipids with, statins, and if they have really bad hypoalbuminemia, you may also want to give them some thromboprophylaxis as well. Some patients may even require, prophylactic penicillin if they are predisposed to getting infections. Generally speaking, with progressive glomerulonephropathies, in particular the rapidly progressive ones, but the refractory ones and the ones that we know will progress unless we treat, we will give them immunosuppressive therapy, which is usually steroids, and it may also involve cyclophosphamide. It may involve calcineurin inhibitors such as tacrolimus, cyclosporin, and often mycophenolate can be used instead of those two if they're not tolerated. Sometimes we can also use plasma exchange. Plasma exchange is essentially where we take a patient's plasma, the plasma in their blood, and we swap it for some fresh plasma. And that's because it has all of the circulating autoimmune antibodies and things like that that could be causing the disease. And this is something common in, for example, ANCA-associated vasculitis or anti-GBM disease, which are very sinister, very rapidly progressive, mean causes of renal failure. The last thing I want to talk about is why glomerulonephropathies, nephrotic nephritic syndrome is quite a complicated topic. And that is the fact that, the names of certain subjects, I won't say diseases, I'll say subjects in glomerulonephropathies can make things confusing. So, minimal change disease is a disease. However, FSGS is thought of as a disease, but it actually isn't. It's just a histological pattern that is seen in a group of disorders which are actually all quite different. So FSGS is made up of 6 different types. One of them is primary, but it's not really a primary type because all of the secondary types, all of the 5 other types, you know, they all have different etiologies, but the primary type has its own etiology as well. So it's all very confusing. The primary and secondary types in FSGS sort of suggest that the secondary types lead to the same etiology as the primary type, but it doesn't. And then you have things like rapidly progressive glomerulonephritis, which is actually, what we use to describe ANCA-associated vasculitis and anti-GBM disease, which are different diseases in themselves. And rapidly progressive glomerulonephritis really just refers to how rapidly and progressive a certain disease is, but we use it to describe these 2 actual diseases. So things can get very confusing. I hope I haven't muddied the waters too much. I hope you found this video useful. I will be talking about the glomerulonephropathies in a lot of detail in the coming videos. I want to give you more detail than you probably definitely need to know for the exam, but enough detail for you to understand exactly what I'm talking about. Because the problem with this subject is it's really difficult to actually learn for an exam because it's so hard to understand. And when you have differing levels of detail in exams, in books and online, you don't know what to learn because a lot of these things contradict each other. In an exam, for example, FSGS, they will often, be talking about the primary type, but then they'll also ask you a question about a patient presenting with heroin use or HIV, and they'll be talking about FSGS. But it's very unusual because they ask you in a stereotypical way, which is actually untrue and false for many of these diseases. Minimal change disease is not completely benign, and it's not always completely treatable. But in many exams, that's kind of what they're saying. So I want you to understand it, and I will also teach you everything you need to know to pass these exams, the sort of stereotypical questions I'll ask and the stereotypical subjects that you need to know about. There are some very rare topics that they actually focus on a lot. So ANCA-associated vasculitis, anti-GBM disease, they're incredibly rare, incredibly rare diseases, but they're incredibly popular in exams. And so we'll talk about them in depth here. And remember, this is very important for passing your postgraduate exams and your MRCP exams. And if you watch all of my videos, I can guarantee you'll be good enough to be a renal doctor. Thanks for watching.